Welcome to State of Reform's virtual series, 5 Slides We're Discussing, with some of healthcare's most thoughtful leaders. And now, the host of State of Reform, DJ Wilson.
Hello and welcome to 5 Slides We're Discussing. This is our inaugural edition, launching a first series for us in this time of COVID, where we want to recognize that nobody's in a hurry to get in a room with another 500 or 600 people, but everybody is struggling with some of these same challenges related to COVID, both personally from a social isolation and of course social distancing perspective, but also as healthcare professionals, as health policy leaders, senior healthcare executives. We're grappling with how we can best serve our communities, how we can share ideas, and how we can collaborate in this new order. We have about 550 folks as of this morning, maybe upwards of 60 by now that were new in Pacific time. About 550 folks registered for this first conference, and we're really excited to have you with us. Before I jump into our guests for today, I want to just talk a little bit about the intent here and what we're hoping to achieve and hoping to provide to you. We recognize everybody has plenty of meetings to go to, and Zoom fatigue is a real thing. And so our purpose is not to have just another meeting. It's not to have another video call just for the sake of having it. We're trying to build a very interactive experience, and this is our first step in doing that. So as you look on your platform, you'll see a list of Q&As. There's already people speaking up and jumping in, saying that they're good and ready to rock and roll. I appreciate that. And so feel free to ask questions, pose those there, and then vote for them. If you see something that is a question that you'd like asked, you can hit the upvote question. That will rise that relevant question to the top. I'll see that and I'll be able to ask our folks here. For a little more background, I guess, we're building a really unique and customized platform for conversations like these that will roll into our virtual conference setting. But we're doing it incrementally, learning by doing and one step at a time. So we'd really like your feedback on how this goes, both from content, but also technical perspective as we roll through this. So without further ado, let's jump into our conversation today. We've got really two of the most thoughtful folks in Medicaid in the Western United States and probably the entire country, frankly, given the leadership of Washington State and California, and given the leadership of these two folks in their respective communities. First, we have Dr. Barsam Kasravi, the President and CEO of Anthem Blue Cross Medicaid of California. Barsam, thanks for joining us.
Thank you, DJ.
Yeah, and Peter Adler, the President of Molina Healthcare of Washington. Thanks, Peter, for making time to be with us today.
Thanks, DJ.
And let me preface also by saying a personal thank you to you both. You've both been very strong supporters of our work at State of Reform. I appreciate it. It's meaningful. And thanks for being the guinea pigs as we try to figure this stuff out. So let me start by asking you first, Peter, give me a sense, give our folks a sense, because we've got a very diverse audience. They're not all from Washington State, of course. Tell us about Molina. Tell us about the place that Molina sits in terms of Washington State Medicaid. Give us a little context for your plan.
Happy to do that. In Washington State, Molina Healthcare is one of 5 Medicaid MCOs, and we have about 850,000 Medicaid members in the state. We're about little over 50% of all managed Medicaid in the state, and we have been here for over 20 years, almost 25 years now, serving all counties and all regions of the state. And just recently finished, under the leadership of the state, the integration of the behavioral health benefit with physical health benefit. So mind and body are finally connected in the state of Washington. Molina also operates on the exchange in Washington and also offers a Medicare dual eligible product in the state as well for low income individuals on Medicare. So all told, we're a little over 900,000 members and have been here for a long, long time.
Awesome, good stuff. Barsam, how about you? Give us a, a sense of how Anthem Blue Cross fits within the Medi-Cal framework in California.
Sure. Yeah. So Anthem in Medicaid in California, we've been here since 1994, about 25 years. Started in Sacramento County. I'm sure most of you are familiar, at least in California, you know, the contracts are given more or less by county. So we are currently in 29 counties across the state, about just shy of 1.2 million members. Very interesting seeing the difference between the various counties. I'm sure we'll get into moving forward and future discussions today. We do have commercial, Medicare, and the exchange in California as well. So work very collaboratively across lines of business to work with providers, work with different communities, counties, and our membership. And really been here 13 years, started as a chief medical officer, now in this role, and really enjoying collaborating in the various counties and the diversity of California. It's really been a learning experience of how what kind of diversity and difference there are from county to county when it comes to healthcare.
Yeah, good stuff. We're going to get into our slides now, and just to revisit our premise here of this series, the idea is that each of our panelists will bring one or two slides that they think are interesting and worth teeing up in a diverse audience of senior leaders across silos. And to start, though, I'm going to be teeing up one panel, or one rather slide for us all. And I want you, Barsam, to kind of kick this off, and Peter to follow up. And I'll just ask you, these are images of the diversity, really the county by county infection rates in Washington State and California. And to varying degrees, these are seen across states, and they're seen within states across the country, where some regions are just hit harder than others. There are political reasons, or maybe not political, but there are community reasons or social reasons. Maybe there's a political, cultural reason baked in there. I'd ask you both, why do you think, first, Barsam, to you, why do you think, what are you learning? What are you seeing in the geographic diversity, sometimes the demographic diversity, which is important to note? What are you seeing, and what are you learning about the way COVID has been infecting communities in California?
A great question. I think this, if anything, any takeaway from this slide is to say all healthcare is local. And it's never been more true than I think with COVID. There are so many factors that go into, from my public health background to looking at this slide. I think, that's the one thing when I moved from commercial to Medicaid, realizing how different every county in California is, from the diversity of the membership and the population. You move from a San Francisco to an Alameda to a Santa Clara, almost night and day when it comes to the population. The provider infrastructure, the county infrastructure. What's specific to COVID, I think you'd have to consider the level of testing with each county. Recently been on calls with LA County specifically. Now, a lot is determined by the county public health leadership. And every county has different public health leadership, different numbers they're reacting to, different facilities, different areas of focus, whether it's nursing facilities, whether it's hospitals, whether it's the homeless population. It really goes to the diversity and richness of the state by county. I think you have to look at testing levels, and some counties started testing sooner than others. The social distancing measures that at times were different by county, less restrictive or more restrictive sooner than when the state implemented theirs. And just I think the culture of the counties, the culture of the cities, whether they're urban, a lot of interaction, especially before the social distancing even went in place. Public transportation, the number of homeless population, number of skilled nursing facilities, hospitals. So there are so many factors that go to this, but at the end of the day, healthcare is local. Every county has somewhat independence in determining some of their public health measures, which I think is a good thing, but at times, like COVID, it does lead to some variation. And I think the healthcare infrastructure is so different in the various counties, and that I think leads to access to testing, access to healthcare, access to your providers. And so I think that is what you see in this, at least the map on the California side.
Here, where does, we have a screen here that shows clearly the geographic diversity, and for folks that aren't familiar with counties in Washington State, the three counties on the left are the urban Puget Sound counties around Seattle and Tacoma. That county on the right is Yakima County, still a large rural community, but significantly smaller, about a tenth of the size of King County, where Seattle is. We see the geographic diversity. What are you making of? What are you trying to distill or seeing in the demographic diversity, and how this is impacting people of color differently, people of lower income differently? What are you seeing in the data that you're reviewing?
Yeah, what we're seeing in Washington is a reflection of the disparities in access to healthcare, the disparities in health that have long been there, but that the coronavirus and the pandemic has brought those out, those disparities and those vulnerabilities in dramatic terms, both in terms of the spread of the infection in certain communities, and as in terms of the clinical manifestations of the coronavirus. So, for example, we are absolutely, at least in the Molina population in Washington, we predominantly serve lower income individuals and families, but those lower income individuals who are employed in positions that are often in very close working quarters, that live in environments with multiple people or a much more higher density of people living in the same housing environment, who don't have the opportunity to socially distance the way many others do, of higher income levels and of different working environments. We're seeing our members who had a number of chronic diseases and comorbidities prior to the pandemic are much more vulnerable. In particular, we're seeing that in our blind disabled population in Medicaid, and much higher incidence of rates of positive test results, and in more significant clinical impacts once they do get sick. So these are disparities that tragically have all been there, always been there, and that are driven by education, socioeconomic status, housing, a lot of the social determinants of health, deficiencies, and this virus seems to become much more difficult to control and manage in those environments and for those people.
Yeah. Art Jones, who I believe is the Art Jones that's a consultant at HMA, asks about providers, and specifically FQHCs and the safety net providers, and whether you as plan leaders are thinking about different types of payments to support those FQHCs, those safety net providers, beyond traditional PPS or some of the more traditional, even APMs that were sometimes innovative. He's specifically wondering about a capitation model for FQHCs. Can either of you speak to FQHCs specifically, maybe capitation, or if you'd like, maybe in general about the relations with providers at the safety net level during this?
Well, I can jump in. Safety net clinics, FQHCs, are a big part of our network in California. And in the last year, I would say we actually had been really developing a telehealth infrastructure. That'll go into my first slide, really providing kiosks, iPads to over 200 FQHCs across the state, really to address a couple main areas. One is teletranslation and translation services, as well as access to behavioral health, access to specialists. So there is definitely, for us, a concerted effort to focus on FQHCs, where most of the Medicaid members in California, I would say outside of Los Angeles, do access most of their care in these safety net clinics. And we do have a capitation model in California. A lot of the FQHCs are under that capitation, which I think has potentially helped with revenue stream in times of COVID. But I do think moving forward, we have to build on what we've done thus far to sustain the infrastructure that a lot of these clinics have put in place on televisits, telehealth, access to specialists through telemedicine. I think those are areas we're focusing on, because the Medicaid membership will continue to access these clinics, these providers, and we definitely need to make sure the providers have the tools in this new world, very different than the previous world. And that includes payment tools, but it also includes other technology tools that some FQHCs are way advanced in some counties, but others need a little more support. So we're looking at more specific interventions and support that comes in the form of grants for some clinics. And we had done a sort of a survey of the clinics to see what type of infrastructure needs they need. And a lot of it came around telehealth and technology, but there were other areas that we wanted to continue to pursue as well for certain clinics. So definitely a big strategy for us in California.
You mentioned your telehealth slide, and I know, Peter, you've got some thoughts on plan-provider relations that I want to come back to. But Barsam, let's tee up your telehealth slide. Tell us what's going on here and walk us through it.
Sure. We've been looking at telehealth, I'm sure all on this call can say, probably over a decade. We started with bricks and mortar video, audio at various clinics when we had our rural contract, I'd say over a decade ago. It was called the CMSP contract. And, I'd say the utilization has continuously been slim. And we look at telehealth in two angles, and there's various ways to define it. One is really supporting the providers in telemedicine as the members want access to providers, and then other telehealth tools that the members can have at their disposal if they are restricted as far as access to specific parts of the healthcare system. So when we looked at our provider infrastructure, there was not a lot of utilization, whether it was by the providers or by the members, wanting to access the Medicaid providers. And we had developed various tools. We had supported, various infrastructure and marketing efforts. But the second COVID hit, I would say within 24 hours of the lockdown, the social distancing and the quarantines, it was just, and I think Peter will talk about, like night and day. I mean, I had probably 35 texts within 24 hours asking me what codes they need to build. My physician friends, a lot of my friends from medical school, a lot of providers that had my access to my cell phone asking, how do we bill for telehealth again? What exactly is the telehealth process for Anthem? And so that was great for us because we had been trying to promote, standard telehealth visits for years. So as you can see on the right, that shows up in our claims data when it comes to using, general telehealth. I think providers had some of these tools, but either they were not necessarily looking at it as the main source of healthcare, of providing healthcare, or the members were just not early adopters. So, one of the silver linings, I think, with COVID is the, accelerated innovation, I call it, when the status quo is just not sustainable to adopt telehealth. It really had to be both the members wanting it and the providers accelerating their adoption to have this type of surge in utilization from what we've been seeing in the past. So definitely wanting to build on that, as you said in your intro, DJ, there's different, and Peter as well, different ways that people are looking at providers are looking at telemedicine. It's primary care, specialty care. We're looking at it in areas like physical therapy, speech therapy. The state of California is also looking at this when it comes to, adult day health care. There are a lot of areas that are interested in telehealth. I think we're looking at, okay, what makes sense clinically, what makes sense as far as member safety, provider safety, and looking at it collaboratively with providers to say, how can we set that up? And then lastly, on the member tools on the left side, it's really, there's a certain subset of members that, based on access, are not able to either use telemedicine with their provider or access to provider. And we've developed various tools to access urgent care through a telephone app, telepsychiatry. We have a substance abuse program through telemedicine on the iPhone or the cell phone. We talked about interpretive services, and we also have a new artificial intelligence symptom checker, actually a pretty interesting tool where members can actually look at their symptoms, whether it's COVID or other symptoms, and really understand at what point should they access care and what questions should they be ready to answer when they access care.
Yeah.
In summary.
Good stuff. I think this might be one of the big takeaways of the COVID era, right, Peter? How do you see telehealth?
Well, absolutely. I'll share some of my comments from an upcoming slide now and build on what Barsam has just said. We've watched the uptake of telemedicine moved from pre-COVID of about 1,000 a month on our 900,000 members, 1,000 telehealth visits, to we just completed in the month of April 40,000 telemedicine visits, and or the provider network did. And that's truly in 1 month, from 1,000 to 40,000 visits. And when we look at it, a few things are apparent right away. First, it's pretty evenly spread between physical health and behavioral health providers, that those 40,000 visits last month. Second, it is accounting for somewhere between 30 and 40% of the routine visits that were previously handled in office settings. And number three, the member satisfaction levels with the telehealth encounter with their provider are extraordinarily high. And so not only did this move more rapidly than any of us ever could have envisioned, but the profile of the care that's being delivered is very similar to the profile of services that were being delivered under traditional brick and mortar environments. We are certain that this genie will not and should not go back in the bottle once the emergency state from the pandemic subsides. That this is part of the new normal, and really will bring in call to opportunity for us to really rethink the delivery of healthcare, and in particular ambulatory healthcare. We're most likely forever going forward, first encounters between a member and their provider will be a telemedicine visit, and it might be followed by a few other telemedicine visits, and that may be the entirety of that episode of care will be virtual.
Yeah.
And that this is a new normal that is proven remarkably successful in a short period of time.
Shaylin Bravens is asking whether there are specific telehealth platforms that you prefer providers use. Do you guys have preferred vendors in the telehealth space that might help them get up the learning curve, help providers get up the learning curve, or do you stay agnostic in that regard?
With Molina, we've stayed agnostic in terms of the platform that the providers use. We've been extraordinarily supportive of helping practices get up and started, but different practices have different mix of providers and provider types, and have different needs that the different platforms offer. So it has been we've been agnostic about that and very supportive of the providers getting on a platform independent of what platform.
Barsam, are you guys generally also agnostic in that space?
We are. We learned our lesson with EMR that we can't restrict. We can't. Although we might prefer to have a few vendors, but it seems like it's probably going to be even more in the next 2-3 years. I think that it would be nice to have some uniformity in some of the tools. I do like that the state has, and I think CMS has taken away some of the restrictions of video and telemedicine that might have sort of confined some of the things that it could be used for. I hope that continues with caution, obviously, but yeah, we're agnostic as well, California.
Let me ask you both this question. Cindy Robertson, who runs a small clinic in rural Southwest Washington, says many patients don't have access to high-speed internet or cell phone service at their homes. So payment parity for audio-only telemedicine has been very important for rural primary care docs and providers. Do you anticipate audio-only services remaining a covered method of telehealth after the pandemic as well?
Well, it's funny you said that, because I just had an audio visit yesterday for my son with our doctor, and it was a pediatrician. Asked a few questions about symptoms. So I think
they are. Go on.
Oh, sorry. I was just saying, I think clinically, if it makes sense, we would support it. If there are areas where audio could be just as good as as video, but there are areas where, like dermatology, obviously, or other things where clinically it might not make sense. So I think where it makes sense, again, same with telemedicine, clinically where it makes sense, we should continue to support it and even build on it. But we also have to see where it might not necessarily support the business model for those specific specialties.
Peter, how about you? Will audio only telehealth, telemedicine be around after the pandemic?
We hope so. We think to Cindy Robertson's question that for those members who are in particular in rural areas or in isolated areas just geographically, that it's a necessary reality. In addition, we've been purchasing telephones and telephone service for a number of our members now who didn't have that going into the pandemic, recognizing that this is their only link to healthcare at this point in time, and we would like to see that continue.
Let's dig into your first slide, Peter. It's a visceral one. Many of us from Generation X can relate to it. Why don't you walk us through your first slide that you've got on offer for us today?
All right, thanks. So this is obviously Indiana Jones, and who realized that he was at a what one would call a catalytic moment, that suddenly if he didn't make a very quick set of decisions, he was going to get completely run over by the rolling rock. The metaphor here is that the pandemic has brought speed to our reality in healthcare and certainly health plans, as well as for providers to move very quickly. Had anyone said in 1 week, we want you to move to configure your systems and support your entire network statewide on telemedicine and to pay at parity, and to do so with both HIPAA and non-HIPAA compliant devices, I would have said, you're nuts. And yet we did that. Barsam mentioned the member interactive AI feature. We added a bot on our website when our members needed communication, and we had one that allows them to self-diagnose and be able to determine their next steps of care. We developed that bot with Microsoft in 3 days, and we had 100,000 hits on that bot in the first week, and meaning that would have taken months to develop in the past, and with a lot of delay and consternation. Likewise, with the provision of the pivoting to provide, we weren't in the PPE business 2 months ago, but going back to the community health centers, who are a core part and a key part of our network, most of whom are already on capitation, their greatest need was support for telemedicine and PPE. And we just placed another order for hundreds of thousands of dollars of PPE to help support our provider communities. The point of all of this slide is moving quickly is now the new normal. The need to move very, very rapidly, and to not assume that which was fixed yesterday is necessarily fixed anymore.
Yeah. So Barsam, if I can build on Peter's analogy, there's the one big boulder of the shutdown that forced rapid and immediate change. And then there's this other boulder that's coming, and Marion Mulkey asked the question about what Medicaid plans are doing to prepare to respond to the Medicaid enrollment resulting from job loss and declines in income, and how are plans trying to get ahead of that wave? How are they helping or thinking about helping to ease transition of folks who will have just gone through a really painful personal time, losing their jobs or loved ones, and now in the safety net? How are you thinking about that next big boulder that's coming of enrollment increases?
Yeah, very good question. I mean, we're doing a lot of modeling. You know, it's hard to know. There's two factors that are potentially going to cause Medicaid growth. One is the stopping the redetermination, and members that would have either not redetermined or been potentially kicked off of Medi-Cal will stay on longer. So that's more of an immediate growth in the next few months. And then to your point, it's the unemployment and the long-term potential recession. So we're looking at, short-term growth, long-term growth. The membership that we are retaining, that we know what their risk factors are, what their social determinants are, what the needs are clinically, socially, as much as we can. And we're trying to scale our internal staff, clinical, all the staff that look at and work with our members. We're also looking at, as you mentioned, the members, the patients that are going to be coming in due to unemployment, due to the recession, and they are going to be different. They're going to be different than potentially members we've had now. We had the recession about a decade ago, I would say, where we did see growth as well. Now, this membership, again, the subset of sectors that are affected by COVID are potentially different than a previous recession. So we can't necessarily assume they're going to be the same subset of patients and members with the same needs. So we will have to carefully look at their specific needs. Now, they're not necessarily going to have an aid category in the data, but we will be looking at, the same way we did with the seniors and persons with disability. We would have to do an initial risk assessment, health assessment, and understanding their needs, because to your point, they might have a specific age category, a specific background, specific needs socially, clinically, and that's something we have to assess as they come on. I would also say the provider capacity is important to think about here too. With the states being challenged with revenue and budget, I think the Medi-Cal providers, the safety net providers, are ones we have to continue to support. I know in California, we were looking at other types of healthcare providers beyond physicians, nurses, social workers. We have to start thinking about if truly there is a surge in Medicaid members, and now we have this new healthcare environment with telehealth and access to care, how can we set up a provider infrastructure, a healthcare infrastructure that can serve the increased capacity, the increased membership coming in?
So Peter, we're going to transition to your next slide here in a second, but since it's just you, me, Barsam, and maybe a couple of beers on the counter here, why does it take a boulder coming at the healthcare system to drive forward some of these things? Why does it take a pandemic to make telehealth a reality when we've, as a collective, have been talking about telehealth for a generation?
I think we'll be looking at answering that question for decades, probably, but at least in the early analysis here, the changes that needed to happen that enabled the creation of a bot with AI in it, or moving to telemedicine in a week, were in part based on the removal of a lot of rules and conditions that had built up over time in the reimbursement environment, the regulatory environment. There was very quick action in both Washington and California by the governors, by the Medicaid agencies, and by CMS to very quickly move to reduce and remove a lot of the barriers that heretofore that we had all needed to work around. Yeah. Second is just the reality of survival. It was clear that we didn't have time. We all think, I think systems and work environments, social structures assume there's time for decision making, for methodical, stepwise actions which get evaluated and then updated. And in a moment of true crisis, it was a call to leadership, both within the health plans, I would say, and within our state environments and with our providers. And I have to give a lot of credit to our provider community who were doing drive-up clinics and being extraordinarily creative in how in those first few days telemedicine was being delivered. Necessity is the mother of invention, and we are seeing that right now. And it's producing refreshing results. It
Let's
did
look
take
at your next slide here. Do we get you there, Peter? Glitch. I want to move to your next slide here, Peter, because I know it's another metaphor that Generation Xers will appreciate. Tell us why you brought this slide to this conversation.
I brought this slide obviously from Star Trek, and when the Millennium Falcon goes into warp drive, the metaphor here is in advance of a catalyst like going into warp drive or something that causes a major change. The universe is fairly fixed. It feels predictable. The stars are where you would expect them to be. And you can do the metaphor back to healthcare. But suddenly when a catalytic event happens, things which were once fixed begin to move and they begin to blur. And so I'll share some very, very real examples. We've all been very focused in Medicaid in this country, certainly in both states, California and Washington, around the integration of physical and behavioral health and at times oral health. But those three healths and their integration were important, but we all left one health out, which was public health, or we'll call it the fourth health. Public health was not something that was squarely in the accountability of health plans, was not squarely in the accountability of providers. And as a result, we have been assuming and living a blissful existence that public health lived in the county public health agencies, and that maintaining herd immunity, being ready for pandemics, needing to respond in the ways that we have, was somehow off our radar screen. And I think forever that's now going to change, and for very good reasons. So I can very easily see a place where we're going, where we're going to move away from HEDIS measures that are measuring on an individual provider basis what the percentage of their practice is that's immunized with their well child immunizations, for example, and instead moving to measures around community herd immunity and forcing the point that it doesn't work if only some people are immunized and others aren't when it comes to being accountable for public health, which will then lead, I think, to a much greater degree of collaboration between health plans. This is not something you want to compete on, and between and among providers.
So typically, Peter, one of those stars that doesn't always move very much might be the state, might be the Medicaid agency. And I think California and Washington are ahead of the curve in most instances. Both have been talking about big procurements. CalAIM and the California procurement are on hold for the time being. Washington State has just come through a significant round of procurements. Brian Blackwell asks, what do you make of the Healthcare Authority moving to an open procurement in a number of regions that don't have 7 of the 9 Washington State regions that don't have all 5 plans participating there? Is this the kind of thing, I know plans always have to be careful when they're talking about their state partners, but what are your thoughts on that procurement? Ryan Blackwell would like to know, and I'm just wondering how maybe generally is the plan agency relationship changing during this time of COVID?
Yeah, great question. I obviously can't speak for all the thinking that of the Healthcare Authority in terms of their decision making in this regard, but I think after 3 years of successive RFPs to reduce the number of health plans, which was done for many reasons to enable providers to not have their panels, their patients spread across as many payers and as many plans, and to really allow for a level of collaboration between health plans and a fewer number of them, which helps then drive better standards of standardized practices and supports for providers. I think fewer is better than more in this regard. Multiple health plans create complexity for providers, as opposed to collaboration between and among providers. And in the light of the pandemic, the large increase in not just members, but in utilization is not going to be limited by the current number of health plans. It's really going to be the result of the health plans working with providers, to the question you asked earlier, to develop capacity in the provider community for care delivery that's going to increase as a result of a greater number of people on Medicaid.
Yeah, good stuff. Barsam, I want to tee up your next slide, which has a lot going on, and I won't ask you to read it all. People can read it on their screen. But this is a slide that tells me Anthem is thinking even more about the social determinants, as Peter puts it, the sort of fourth health of public health. Tell me about why you brought this slide, and maybe speak to how Anthem's thinking differently about social determinants these days.
Sure, and there's a lot on this slide. I think the main point is that in Medicaid, as everybody knows, that is the most vulnerable population in healthcare, and we are constantly challenged because, as a physician myself, the medical part is the easiest part to solve. There's medications, there's diagnosis codes in the system. There's evidence-based criteria. It's a social piece that's been a constant challenge. And, with COVID, I think that highlighted the great impact that it had on our members and their social drivers of health, social determinants of health. So, really trying to underscore the basics, the basics of, even before the access to the provider, the access to the hospital is food and housing. And our members that, had challenges with these before, it accentuated that with COVID. So we really started to focus on members who, whether they didn't have food before, or because of the lockdown, they didn't have access to food because of the new environment, really focusing on delivering medically tailored meals to specific patients and members who fit criteria with complex either healthcare needs or social needs. And so we started a meal delivery system and process. And then housing, the homeless population, we've definitely talked about it both in Washington and California for years, but they were at higher risk. They didn't have the luxury to lock down in their house or in their apartment. So we worked a lot with the homeless shelters. We worked on finding housing for members that could qualify, getting them maybe removed from the homeless shelters. There was an increase in homelessness just because of COVID, but what was interesting is we haven't necessarily seen a huge surge in cases. Now that might be because of reduced testing, but really to underscore that the most vulnerable of Medicaid are truly the ones that are lacking the basic essentials of housing and food. And that I think at times we need to really focus on that population, because they're the ones that are the least vocal at times, and sometimes don't get picked up on a data analysis or even member calls or patient calls where we do phone calls to do outreach. So really trying to focus on that membership as the most vulnerable in our population.
So Peter, how are you thinking differently about social determinants? And Sarah Sibley asked a question about social determinants in particular, and I'm going to paraphrase her question. It's not exactly what she asked, but how do you see a health plan, a Medicaid plan, filling in the gaps in the pandemic space between the plans, providers, and the community-based organizations that are seeing a lot of these folks? All those entities were trying to work more closely together pre-pandemic, and then everybody's house caught on fire. How does the plan try to fill in those gaps in those spaces where the community-based organizations are struggling?
Great question. We've embraced a number of social determinants of health activities now in the last 2 months during the pandemic. I mentioned earlier that we are everything from probably the minor, making sure members who are completely technologically isolated, that we get them connected, we get them phones. we are providing meals now, meal assistance, which is not a covered benefit, if you will, for our members or Medicaid members who do not have access to food and nutrition while they're sheltering at home. We've moved into a partnership with Amazon, where we are paying for up to 90 days of Prime membership for members so that they have access. They can use their EBT cards and they get access to food delivered and covered from under EBT covered services delivered to them at no cost. We are working with around PPE, I mentioned, with community providers, predominantly the community health centers, but some of the community agencies who are truly on the front line and did not have access to PPE. We're not able to get it at times, just as everyone else, but when we can. And so what we've found, and in part to Barsam's earlier comment, social determinants of health is a very local issue, and it's very different in each community in terms of what the needs are. One other thing we've done is we've now pivoted our case managers to operate on a telemedicine platform themselves, so that our case managers are able to do outreach to members as if it was a telemedicine visit, as opposed to the traditional telephonic case management, which has helped bridge some gaps in care during the time that the community agencies and providers are truly struggling.
Yeah.
I don't know time going forward where health plans in the Medicaid space cannot be actively engaged in the social determinants work.
Yeah. Barsam, question from Michael Erickson, who I believe comes to us out of California, is asking about provider withholds, which were a standard part of risk-based contracts in the pre-COVID world. He's wondering if those withholds ought to just be released to support providers during this time and maybe rethink value-based payments. And I'm wondering if you, maybe more generally, if you have thoughts on this sort of question about whether providers, particularly primary care providers, will end up bearing the brunt of a lot of this financial pinch.
Good question. I don't know if we necessarily do provider withholds in our model. We definitely have a lot of quality incentive programs in addition to the capitation rate. So we do, the capitated model, I think, has some protection on this decreased utilization as far as the COVID challenges. So, and we are looking at our value-based programs, actually revisited what they were focused on, given the changes in, as you mentioned, Peter, HEDIS, and we really try to tailor it more around telehealth and specific HEDIS measures that would still be applicable, and accelerated those payments. We're actually sending those checks out tomorrow. We're accelerating all of our P4P payments for all the safety nets, all the clinics across the state. We don't have necessarily withholds. Most of our models are capitation. We are looking at, as Peter mentioned, if we're looking at providers and clinics and IPAs, what will be a measure of quality moving forward? What is the measure of a collaboration between a health plan and a physician or a provider group? I think the old days of immunization rates and A1C tests, what else can we measure from a public health standpoint, from a telehealth standpoint, technology? How else can we support providers to get them to a new normal? Those are all the areas we're looking at, as well as different financial supports, as I mentioned, whether it's grants, whether it's increased capitation, whether it's focusing on supporting the telehealth infrastructure.
We're getting near the end, and one thing I've learned about this COVID time is that it's important to try to give people 5 minutes for their next meeting. So in the interest of trying to wrap things up here in the next minute or two, Peter, I'm going to ask you both this question. Peter, I'll start with you. Reflecting on just the craziness that is 33 million people newly unemployed, and 92,000 people dead in the United States alone, and just the enormity of the moment in which we find ourselves. What advice or counsel would you give to healthcare policymakers, to senior healthcare leaders and executives? What counsel do you give them as they try to navigate through this really choppy time?
I think one piece of counsel would be that we are not in a temporary crisis, and that the world as we knew it is not the world we're going back to. And so as we envision opening up our communities and our provider and our healthcare, we should not be thinking about returning to the same services delivered in the same ways that they were before, and that we are in a new world and a new environment, and the lessons learned of moving quickly, of removing artificial rules about what a visit is, whether it's on a telephone alone or a telephone with video, just using that as a small example, that we are not going back to the past. Yeah. And then second would be my point earlier about public health, community health has got to be the fourth health, and along with physical, behavioral, and oral health, and has to be embraced and reimbursed and included in both health plan and provider relationships going forward.
Yeah, great stuff. Barsam, how about you? What advice or counsel would you give to senior healthcare executives or policy leaders as they try to make it through this time?
I think this was, for us, a lesson that we started to learn during the wildfires here in California. Is really when you have disasters like the wildfires, like COVID, it really calls for true leadership and collaboration. I think collaborating, healthcare has been challenged mainly because you have various stakeholders that have different interests. And I think when you have a common enemy, which is a virus or a fire, that is when you put down the walls and you start thinking through how can we support the true healthcare infrastructure. So I think we shouldn't forget that lesson as we go back to potential new normal, that health plans, hospitals, safety net providers, the state, regulatory organizations, we all need to start focusing on how do we better integrate, talk more to one another, and it doesn't have to always take an emergency situation for us to rapidly execute as we did in this experience. So really taking those lessons learned, as Peter mentioned, but also trying to break down those social distancing walls and getting more integrated with one another.
Yeah, great stuff. Dr. Barsam Kasravi, the President and CEO of Anthem Blue Cross Medicaid of California and President of Molina Healthcare of Washington, Peter Adler, thank you both for doing this with us and sort of kicking off the rust and dust as we work through this first in our series of 5 slides we're discussing. And thanks to you for joining us in this conversation. We'd love to hear what you thought about this. We'll send you a link and ask you to answer a few questions. And of course, you can always just email me directly at djwilson@stateofreform.com. I'd love to hear what you thought. Thanks for joining us. And we'll do it again next week when we talk about philanthropy's role in addressing this COVID response. Take care.
Thanks for joining us in this virtual conversation and for your support of our work at State of Reform.